Good evening and welcome to this webinar. Unfortunately, we don't have Peter de Jong with us today, but we do want to wish him congratulations on his birthday, and I'm sure he's enjoying it somewhere with Marie, and yeah, we do miss him. So today you only have me, and so we'll be jumping straight into it. We do want to thank you very much to Stellis for the sponsorship of this webinar tonight, and we will be focusing specifically on what are the products, or a number of the products, including Betmega and VC Care for the session. So thanks very much to Stellis for contributing to tonight's webinar. And then next week, I want to remind you we have an excellent talk. Trudy Smith will be speaking. She is an excellent presenter, and she'll be speaking about the best option for menopausal symptoms. And I'd encourage you to all join that. Her talks are very practical and very, very useful. So I'll invite you to join for that. So yeah, so before any further ado, I'm going to jump straight into this talk now. And so the talk was advertised as advances in the treatment of overactive bladder. And I think we're going to have to save the questions for the end so that we can, I can answer them, because we don't have any host or anyone else with you. So we've only got me tonight. And yeah, we're talking about advances in the treatment of OAB, which most of you know is overactive bladder. But I will be talking about some other confusing bladder symptoms that we always see and that we sometimes struggle to really understand and dissect out with our patients. So just starting with some basics, the classification of incontinence, and remember that in addition to the most common ones, which are the patients with stress incontinence, patients with an overactive bladder, which is also often called an unstable bladder, and we know we often get patients with mixed symptoms, but you do get patients presenting with incontinence more related to avoiding dysfunction, which could be either a detrusor muscle failure or due to a problem with avoiding obstruction. And then you also get patients who might have some congenital functional disorders. Functional disorders could include patients with dementia, etc. And then you can obviously get the congenital and fistula types. But just as a reminder, a lot of patients presenting with an overactive bladder do have an overlap, which includes a stress incontinence. And that's about a third of patients having both stress and urge incontinence. And these can be quite difficult patients to sort out. But just as a reminder that if the patient's got urgency, there's also a good chance they're going to have a combination of urge and stress incontinence. So just again, as a reminder, patients who have urgency present with the feeling of needing to rush to the toilet, not being able to make it in time, and then passing large volumes of urine before making it to the toilet. Whereas the patient with stress incontinence very more specifically related to coughing, sneezing, laughing. I'm seeing a lot of patients who want to run, jump on the trampoline, all sorts of things, and that is more stress incontinence. And just as a quick basic reminder, the treatments of the urge incontinence more and more related to medication, and the stress incontinence is surgical. It is an important distinction to make. So let's just really look at some of the important symptoms. Nocturia is a very important symptom because in my mind, it gives me an idea as to whether the patient has more of a stress incontinence or more of an overactive bladder. If the patient doesn't have any nocturia, then it is more likely to be stress incontinence. We know that frequency is a common symptom, and it can be related to both an urgency and a stress incontinence type picture. And then really just trying to dissect out the differences between an urgent incontinence and stress incontinence. And it's really important to ask patients if they have prolapse. Prolapse can be related to both urgency and stress incontinence, and something that we do need to look at. There are three symptoms that I specifically call red flag symptoms. These are the types of symptoms that you really do need to try and investigate a little bit further. If the patient's got voiding difficulties, they say they sit on the toilet, the stream is very slow, They might say that they double void. They might have hesitancy or post-nutrition dribbling. All those types of symptoms do need to be looked at in a little bit more detail, because specifically, if you go in and operate on these patients, it can be very difficult to work out exactly if it is a stress incontinence or not. And if they're avoiding difficulties in addition to their urgency or their stress incontinence symptoms, be a little bit more careful. And these are the sorts of patients why you might want to send for urodynamic testing. Hematuria is a very important symptom as well. Specifically, think about anyone with bladder cancer. And remember, although we don't see a lot of bladder cancers as gynecologists, this is a very real condition, and anyone with hematuria might have something else underlying. So those are the sorts of patients you might want to then do a cystoscopy on, or refer to a urologist for further workup with, in addition to that, maybe upper tract imaging, etc. And then bladder pain. Patients with overactive bladder don't get bladder pain. And so think about other things. We've seen patients with stones with bladder pain, and then obviously interstitial cystitis, which we will look at in a little bit more detail later on in the talk. Don't forget about the general medical history. Not common, but patients who've got neurological disorders, multiple sclerosis, Parkinson's, stroke, and I haven't put it on there, but even patients with spinal cord issues can present with overactive bladder. A lot of patients have had now had some slings. They might have had mesh surgery. A lot of patients don't know what they've had. And so ask them what they've had. Remember, a patient who's had a previous sling and might have been placed into the bladder. She might have an exposure into the bladder. So these are the sorts of things you do need to think about. And obviously, anyone who's had previous vaginal surgery, there could be a rare patient presenting with a iatrogenic fistula. I've seen that before. So get that history from the patients. Theoretically, you can get incontinence from varying medications. I think specifically on this one, diuretics can worsen the patients with severe overactive bladder, and so that's something that you do need to think about. And I find that a lot of patients will walk around with quite significant fecal symptoms without specifically telling you. They've done research in the UK where they found that it takes on average about 5 years for patients with fecal symptoms, and specifically fecal incontinence, to present for help for these symptoms. And so don't forget to ask patients about the symptoms of fecal incontinence. And on this slide, you'll see defecatory difficulty. A lot of that is potentially related to a rectocele, which could also specifically present with urgency and overactive bladder type symptoms. So ask the patients about defecatory difficulty as well. And then I don't need to tell the gynecologists in this on the session today, but sexual dysfunction is also quite common, and we do need to ask patients about that, and that does form part of the constellation of symptoms that these patients with pelvic floor dysfunction present with. So I have a few basics I do when a patient presents to me with incontinence. I always ask them to come with a full bladder, and you do need to prime your reception staff about this, especially if you're running a bit late and they want to go and have a pee. Keep them with a full bladder before you examine them, because if they have stress incontinence, it might not see it because his bladder is empty. So and I always ask the patient to cough when they're lying supine, but if they don't leak supine and they have a very strong history of stress incontinence, I then turn them onto the left lateral, and with a sim speculum, I then pull the posterior part of the vagina posteriorly, and then ask them to cough in the left lateral. And you often do then see a leak, so that's also something else to think about. Bear in mind, though, that the patients might have what we call stress-induced detrusor overactivity, and that might just be a small little caveat about a patient you see who leaks on coughing. So just bear in mind that it might still be detrusor overactivity. Urogenital prolapse, always look for that. And atrophy is very common, and the intravaginal hormone therapies are remarkably underutilized in our setting. So don't forget to look for atrophy and treat it accordingly. We have indeed seen some significant improvements in patients with urinary incontinence who we've treated with vaginal estrogens. And again, don't zoom in only on the vagina. We tend to often overlook any anal and rectal symptoms in patients. And patients don't obviously like having a rectal examination, but this is often a very good way for looking for posterior compartment prolapse. And I do a rectal in most of my patients just to see what might be happening there. It also gives you an idea as to what's happening from an anal sphincter point of view. We all know that a dipsticks is something that we routinely do, and you might be looking for some glycosuria. Remember, diabetics can present with bladder problems as well, so don't forget to think about that. And then obviously anyone who's got some blood in the urine, it might be a bladder cancer, so bear that in mind as well. Something I don't do enough of either, but don't forget the bladder diary. And you can actually see this patient presented with a lot of nocturia, and indeed you can see she had a large volume of urine at night. And I sent this patient to a physician because she seemed to have some sort of diabetes insipidus or something. So that was something that I picked up on this patient who I actually did a bladder diary on. Just thought I'd mention something to you that I have actually found quite useful over the years, and this is desmopressin. You can actually see in patients who have only nocturia getting up 5-6 times a night to pass urine, you might want to think about starting them on this. This is DAVP, and this does work quite well in reducing the number of nocturnal urination episodes. And just be careful, it does lead to water retention. So if you do start it on patients, just warn them about the fact that if they end up having any vomiting, diarrhea, or any fluid changes, not to take it. And we also check the blood pressure, check the renal function and electrolytes before we actually start them on this tablet. But this is something that we don't often think about. It's actually quite a cheap medication. And I would normally start the patient on 0.1 milligrams. You can move all the way up to 0.4, 0.5 milligrams of desmopressin. And that's something that specifically is useful in patients who have a lot of nocturia. But unfortunately, we don't have a lot of patients who present with a isolated nocturia. And then the next thing I'd like to mention to you is that in the patient who is presenting with any type of incontinence, I think it's important to check the residual. So my routine is to get the patient to go and empty a bladder after I've examined her with a full bladder, bring them back and then do an ultrasound and see if there is any urinary residual. And it's very simple to check the urine volume. You can just check to the 3 measurements, A times B times C, and we multiply that by 0.6, and that then gives you the volume in mils. And we've already seen the slide. I think Pete even showed it last week. So again, just to show you, a patient presenting with symptoms that sound like an overactive bladder might indeed not have an overactive bladder. And so, yeah, I think it is useful to try and dissect out what might be happening from a symptom point of view. And something I do find very useful is a perineal ultrasound. I've shown this picture before, but I use a simple curvilinear ultrasound probe that you use for your fetal assessment. And this is the picture that I get. So this is I have a glove that I place over the end of the probe. I put some gel over the probe before I put the glove on, and then put some gel on the outside of the glove, and then place this in the sagittal plane over the perineum, and then you get this picture. And with enough practice, you're able to get this picture quite nicely. The symphysis is a white line over there. You can normally very easily see the urethra, and you can see the bladder and bladder neck. But all I wanted to show you in this slide was just that measuring the true wall thickness will give you a good idea as to whether this is actually an overactive bladder or whether this is more related to stress incontinence. And so what I normally do is I just measure this traducer wall thickness, and if it's more than 5 millimeters, it then helps me to tell if it is actually an overactive bladder or not. And so this patient, as you can see, has got a very thick detrusor muscle, and if she presents with incontinence, and the symptoms do specifically look like they are urgency type picture, then this would then confirm this is an overactive bladder. This was looked at by Peter Dietz in more than 600 patients, and it was associated with very good specificity, but not a very good sensitivity. So it's just something that I add into the whole equation when I'm assessing these patients, and it then gives you a good idea as to whether this is actually an overactive bladder or not. So the condition that I found is also very undertreated, that is bladder pain syndrome, or what it was previously called interstitial cystitis. This is a condition that hasn't been very clearly defined. It's not very well diagnosed. It's remarkably undertreated. And most of the time, these patients have seen their GPs, who then just give them repeated courses of antibiotics and tell them that they've just got recurrent bladder infection. So it is something that I find to be very important to go and look for and to think about. And what I normally do is, in a patient with recurrent urinary tract infections that have pain between the UTIs, people who have bladder pain that is then relieved with a void, those are the types of things that you need to then think about, whether it is specifically more of interstitial cystitis rather than a bladder pain syndrome. So this is the kind of picture that you might see on a cystoscopy. And in this patient, I would have stretched the bladder and then emptied. And as you refill, you then start to see these leakage episodes, these sort of hemorrhages on the screen. We've all heard about the Hunner's ulcer, which is quite a severe form of hemorrhaging on the screen. You get flame hemorrhages. This is the kind of thing that you only often see once you actually filled, emptied, and then refilled the bladder. So patients do often present saying that they've had a cystoscopy somewhere and they didn't find anything. And when you go back and look, you indeed see a normal bladder when you first go in, but as you fill, empty, and refill, you then find that these patients have this sort of picture. And it is very good once you've made this diagnosis, because you can then move on to counseling patients about the diagnosis and starting some treatment options. We do biopsies of these patients, and again, that also helps us to move on to diagnosis. Good pathologists will normally diagnose interstitial cystitis if it is there, and looking for mast cells. There is a new classification for interstitial cystitis, which includes the number of mast cells that they count per high-power field, and I think it's 25, but I would be open to correction. Just wanted to mention some new things in interstitial cystitis. This was just a study that looked at the use of cystostat, and it did actually find, which is hyaluronic acid installations, and it did indeed show that there was some improvements in this blue column, which is the cystostat or hyaluronic acid group. So that is something that I use in my patients quite regularly, amongst other things like mast cell stabilizers, montelukast, and Phenergan. But this talk isn't really about interstitial cystitis, but just wanted to highlight the fact that this is something you do need to think about in patients who have symptoms that might be suggestive of overactive bladder as well. There you can actually go. I do a lot of montelukast, use a lot of Phenergan in these patients, and it is something that you start empirically if you think it is more related to interstitial cystitis. Again, don't forget about cancer. That might be a good reason to resort to an early cystoscopy in a patient who isn't responding to your oral medications for overactive bladder. In this day and age of where there has been a lot of mesh, specifically the tapes, don't forget about a mesh complication. This is a patient that I saw who had significant urgency incontinence, some irritable bladder symptoms, and you can actually see a TVT that was placed right through the urethra. And so that is something that one needs to think about. This is another one who had an exposure or erosion into a bladder, and this patient also presented with some urgency symptoms and recurrent urinary tract infections. Prolapse is understated in its association with patients with overactive bladder, and I think it's very important to look for prolapse in these patients and specifically consider a repair. Etienne Hen did his whole PhD on the posterior compartment, he was a gynecologist who worked in Bloemfontein. He's now working in Namibia. But as you can see, this is from one of his papers that was published in the International Urogynecology Journal. And he found that in patients who had overactive bladder who had treatment for their posterior compartment had significant improvements in their symptoms of overactive bladder. So if I see a large rectocele in a patient with an overactive bladder, I will obviously counsel them, and maybe you can try them on some empiric medical treatment. But before you go on to more advanced treatments, I think it is important to consider doing a repair of that posterior compartment prolapse. And this is just something that I think is important. Sometimes you will go and do a vaginal examination and you won't specifically see posterior compartment prolapse, but if you go then and do your perineal ultrasound, you might indeed see. And this is a patient that I did a perineal ultrasound on and did a rectal. While doing the perineal ultrasound, you can actually see this quite large rectocele pressing on the bladder, and that does, in my opinion, give rise to significant overactive bladder symptoms as you get this pressure and irritation of the bladder neck in these patients. So I know it's not very widely discussed, but I do think that resorting to treatment of this posterior compartment does help a lot of these patients, and it might give a permanent solution to these symptoms, which otherwise would be requiring long-term medication. And then something that we do occasionally see is a diverticulum, and this is a patient who I saw. He has again a perineal ultrasound. He has the bladder. He has this is an upside down, so he has the vaginal opening. This is the head down here, and you can actually see quite a big diverticulum. And this is something that would need to be surgically treated, either by a urologist or a urogynecologist who's got experience in treating this condition. Yeah, what about stress incontinence? And just thought I'd, just for the purposes of the talk, I thought some people might like to hear a little bit about what I believe is still the accepted and gold standard treatment for stress incontinence. So you've examined this patient, you've excluded overactive bladder, you've demonstrated the stress incontinence, and now you want to treat her. What are the options? And I still think a surgical option is still very good. And without a doubt, in my practice, I still find the retropubic TVT to be the best option. This is the TVT tape, and this was the original TVT that was invented by Petros and Ormston. You can actually see there's still this handle that's screwed onto the back of this very thick needle that they then put retropubically. And you can actually see how the TVT sits at the mid-urethra, and therefore supporting the bladder as she coughs and sneezes. And this, in my opinion, still is, without a doubt, the gold standard in treatment, despite all the different issues that have emerged with class actions in the UK and in Australia and even in South Africa. It's just a quick reminder how it works. Essentially, replacing this pubourethral ligament, and it's very nice to actually show patients this picture if you are going to do one of these procedures on them. One of the questions that some people still ask is whether you do the retropubic TVT or whether you go and do a transobturator tape. I very much prefer this retropubic type TVT. This one was invented to prevent the injury to the bladder and also the possibility of retropubic hematomas. But just a quick one, just wanted to run through that. We'll get back to that now, but really just to look at some of the issues related to class actions that are happening and that have happened. You all know about these problems that have been very widely publicized, but really just to show that these things did give rise to a massive decline in the performance of these TVTs and transobturator tapes. And just really to show you some of the issues, including the infections, exposures. I've really seen this picture of the, exposure to the bladder, but really just to show you that from an evidence point of view, the tapes still have very, very strong data, data up to 5 years, showing excellent results. And you can actually see 60 months being 5 years in both the TVT and the TVTO sustaining their cure rates up to 5 years. And indeed, this has been extended in some studies with 17-year follow-up for the retropubic TVT in this group, that the group to invent the TVT. And just to again to show you that the Cochrane review very much supports the use of the retropubic T, where you can actually see that they're the most extensively researched surgical treatment for stress incontinence with a good safety profile, and with the exception of groin pain, fewer adverse events with the transobturator. But still, I think from an efficacy point of view, the retropubic tape seems to be much better. You can actually see this is from the Cochrane review, much lower long-term incontinence recurrence with the retropubic T, with slightly more bladder injuries in the retropubic, maybe a little bit higher voiding dysfunction, but more groin pain in the patients who have the transobturator. So on the balance, I still very much prefer the retropubic TVT. And yeah, you can actually see from this data from Sandvik, women in the TVT group had less leakage during stress and fewer subjective stress incontinence symptoms, and were more satisfied with the operation compared to women with the TVTO. And this is from a large cohort of more than 5,000 women. But let's say you get a patient who still does want to go ahead with something other than a TVT. For whatever reason, you can do a birch copper suspension, and we do them laparoscopically these days. But just again to show you that in this RCT, comparing the laparoscopic versus the laparoscopic copper suspension versus the TVTR, or the retropubic TVT, and again, this was a meta-analysis, a systematic review, and all the data really from a cure point of view favoring the TVT. And overall complications not much different between the two, but operation time obviously quicker for the TVT and hospital stay shorter. What about the single incision slings? The can do something like a Solix or an Altus, but again, I still don't think they've got as good long-term data as the retropubic T. So I didn't actually do many single incision slings as a standalone procedure for stress incontinence. The Bulkamids, not a bad option. This is a periurethral bulking agent. And here you can actually see this is a procedure where you inject a gel, polyacrylamide gel, in 4 quadrants around the bladder neck. And this has become quite popular in the UK, very, very gentle and not associated with almost any complications or side effects. And you can actually see injecting the 4 places gives rise to a closure of this bladder neck. But just a quick short summary, definitely not as good as the tapes, and long-term cure rates, although it says in this 70%, in my opinion, only down to about 50 to 60% cure rates, and very much operator dependent. Laser has been shown to be an option in these patients, although I must say only for those with quite mild incontinence and those who don't really want to go for surgery. And really just if you are doing a tape on a patient, again, provide realistic expectations, choose a procedure that works for you, and be vigilant for post-op complications. So let's talk a little about OAB. That's what we're supposed to be talking about today. Firstly, if you think the patient's got overactive bladder, just run through a differential diagnosis in your mind. And remember, although most of the patients that we see as gynecologists are idiopathic, there are some patients who have either neurogenic or non-neurogenic causes, running all the way down this list, and specifically thinking about something that could be happening in the bladder, including a cancer, stone, or foreign body. So remember, an overactive bladder is to a large extent a diagnosis of exclusion. So you might want to try some empirical treatment from the outset, but you might need to ultimately think about going to the cystoscopy or looking for something further. Okay, so we've diagnosed an overactive bladder, and we need to then think about the treatment. So this is the sort of timeline or treatment algorithm that I would put my patients on. So physiotherapists are very good at helping these patients, and especially young patients, patients who are resistant to maybe going on medication. But I think everybody would do very well to go and see a physiotherapist. So it's not only the patients with stress incontinence, but also those patients with urgency and urgency incontinence. Fluid intake is very important. A lot of patients feel that they have to drink lots of water for whatever reason, and reassure the patients that nothing is going to go wrong if they reduce their fluid intake. We then move on to pharmacotherapy, and we talk about antimuscarinics. So those are your ditropans. Moving on then to your other anticholinergics. I do like VCK, and then beta-3 adrenergic receptors. And the only one we have available in South Africa is your Betmiga or mirabegron. And then I will offer a patient Botox, and then moving on to then giving them the option of sacral neuromodulation. So these are the anticholinergics that we have available on the market in South Africa. And I do like, of this list, I do find that VCK at 10 milligrams to be the most efficacious, and there is data on that, although there might be more side effects. The one with the least side effects is the trucitol or tolterodine, and that at the 4 milligram dose. The trucitol's only got a 4 milligram dosage. Ditropan, we all know that's oxybutynin. The good thing about ditropan is that it's very cheap. It's only about 30 to 40 Rand for a month supply, whereas the VCK, the trucitol can be up to 500 Rand a month. Detronorm, propyvarine, it's a multiple day dose. I think the GPs do seem to like it, maybe because of the catchy name. Lironel is long-acting oxybutynin. It gets absorbed more distally in the large intestine, the small intestine, and might actually work at the higher dose of 20 milligrams. And then Enablex is also just a more specific to the bladder, and also it has lower side effects. But of all the anticholinergics that I use, I do like the Enablex, I mean the VCK. But unfortunately, looking at your data on patients taking anticholinergics, after 12 months, these patients tend to only be taking it at about 50%. And the reason for this is due to efficacy. So we know that most of these patients actually stop taking these drugs after about 3 to 4 months, and it is mostly due to the lack of efficacy. And that is why I like the Betmiga. It seems to have a better efficacy, with at least 40 to 50% of patients staying on it after 3 to 4 months. And just to show you why it works, it basically works on the beta-3 receptor, which causes an increase in relaxation. And it's quite nice to explain to patients that this is a very similar treatment to what you would use as an inhaler for asthma. And they do kind of warm to taking something long-term that is similar to an inhaler for asthma. So a lot of patients obviously resistant to taking long-term medications, but really taking something like a Betmiga is quite, makes them quite comfortable. And just in terms of comparison to tolterodine, some significant improvements with the mirabegron, which is the Betmiga, compared to tolterodine, which is an anticholinergic. Definitely more improvements with the compared to placebo. Okay, but then you get your patients who don't improve on your anticholinergics, that don't improve on your Betmiga. You then need to think about alternatives. And I think the one that is very useful is Botox. So Botox is injected into the bladder. We take 100 units. We take a cystoscopic needle and give 20 injections divided into half a mil each. So that's 10 mils of Botox, where you have 100 units of Botox, 10 mils of saline, and I then give 20 injections into the bladder. You can actually see what we use in theatre. This a special needle, is available from Coloplast, goes through the cystoscope, and you're then able to inject this into the bladder. Medical aids do cover it. We normally do like need to write a motivation letter or two, but most medical aid plans will cover the Botox. Lasts for 9 months, and you get improvements in up to 80% of patients with severe overactive bladder. And this is something which is well within the reach of a urologist or a gynecologist treating these patients. This is the Embark study, which was the Botox registration study. And you can actually see this was a placebo-controlled study. And just looking at some of the parameters, including, maturation episodes, significant improvements. And so I feel very comfortable offering patients Botox. And I do think it's something that we should maybe offer them earlier rather than later. So, but unfortunately, most medical aids will require at least a few months of treatment with one of the medications to show that they then have deserved or earned some Botox. And then the other option in this patient with refractory overactive bladder is sacral nerve stimulation. Now, this is something that we have spoken previously on one of these webinars, but I thought it's important for everyone to understand its role. It does seem like something quite far-fetched and something way off our sort of radar as gynecologists and even as urologists, but I found this treatment to be very useful and a very important part of our armamentarium. And in fact, in my practice, I do a lot of the sacral nerve stimulation. So this is actually how the system looks. So essentially, what you're wanting to do is stimulate the third sacral nerve. So just as a reminder, is the sacrum, and the third sacral nerve root or the fourth do supply the bladder to a certain extent. You can actually see this is a male patient, but in principle, through this third sacral nerve, you are then stimulating the bladder. So this is what the lead looks like. So you've got 4 different points of stimulation of the nerve, and you've got this little hooks that then secure it in the sacrum, and you're then able to stimulate the nerve. And this is how you see it goes into the third sacral nerve root and then stimulates this nerve. We do it under GA, and we're able to find the third sacral nerve root using this sort of landmarks that you get under screening in theatre. And you can then take this needle that is then placed into the sacral nerve, and then we're then able to thread the lead into this needle to then stimulate the nerve. And this video doesn't play. We know that we're in the third sacral nerve when you get a sort of a bellows or contractions of the anus and perineum and a plantar of the toe. And if you get a good movement of both of those things, then you know that you've got the third sacral nerve and you're in the right spot. This is just from some 3-year data. And you can actually see significant improvements in the number of leaks per day and in the number of voids per day. And this is something that we find on a day-to-day basis when we do these patients. So it's something that is very useful and very much a game changer in a lot of our patients with an overactive bladder. Again, moving these patients down into being dry, who were previously wet. And so in those patients who aren't well and that are really struggling, get these patients referred on very quickly for the system. And just again, very good improvements in quality of life in these patients. There was a randomized trial comparing Botox and the system, and in fact, I think they are interchangeable. Not really much difference between the two. So I do discuss both of these options with patients. Just remember, Botox is something that has to be repeated every 9 months, but for some patients, it's much quicker, easier, and something that they don't mind coming back for. Everything has complications. Just wanted to show you that it's not hunky-dory in every patient. This is a patient that got a chronic infection over the lead, and it then all needed to be removed, which is quite painful in these patients. And especially since you've been through the process of getting motivated through the medical aids and sorted out, and you've got to go and remove the whole thing. It's quite painful for these patients. This is another one who got cellulitis around the battery that we put in, and so this is something that I do need to warn patients about. Something I do want to mention: the real use of an intestin is patients with double incontinence. For those who have both fecal incontinence and stressing and urinary urgency and overactive bladder related incontinence. And this is something that is very nice for these patients because it works very well for fecal incontinence as well. And yeah, so that's just a little funny picture, but really just to show you that, you know, patients with double incontinence, very nice improvements. And in fact, as a standalone treatment for fecal incontinence, this is also the first line. So patients with fecal incontinence do very well with this treatment that is indeed covered by the medical aids. So refer for patients for this if you have any patients with those symptoms. This is my last slide. Apologies, I have rushed through some of these slides. So I'm happy. I see there's only one question, and I do miss having my friend Peter Young with me because I'm sure he would have interrupted me a lot more. But yeah, refractory overactive bladder needs workup. So remember, there could be something else underlying. So don't forget essentials, including diabetes and cancer. Botox and intestine have a place, but I think it's very much within your remit to first start them on some sort of anticholinergic treatment or Betmiga. I do prefer Betmiga as a first-line treatment for these patients. Again, you know, the medical aids do cover it on a lot of the plans. But if those things don't work, don't be shy to then consider either Botox or intestine in these patients. So there we go. That's essentially the talk. I think there is one question. So yeah, I think this question was asked a while ago. Sacral nerve neuromodulation for bladder pain syndrome, is there evidence to support its use? Thanks for the question. It's not very high up in the algorithm in the patients, in treatment of patients with this. And remember, it's a very expensive treatment. Number one, it's a very big outing for these patients to have the sacral nerve modulation. And so I think I will try nearly all the other treatments before I end up with sacral nerve modulation. I think it would help with the urgency. It might help with any frequency, but for the bladder pain, I don't think it really works that well. So, and I do have a patient who had this for RC, and she was quite disappointed because it's, you know, you create quite a high expectation, and when it doesn't work, it really is disappointing. Francois R asked, where should we as generalists end in the management of OAB before referring to urogyne, especially in places with no urogynes? Absolutely good question. And I know there aren't a lot of urogynecologists in some of these smaller places. I think I'd be very comfortable for generalists to gynaes or urologists. You know, I think empiric treatment with your anticholinergics or your Betmigas is completely acceptable. So, you know, absolutely start your patient even at your first visit on Betmiga, 50 milligrams a day, see if it improves things. If you do want to be careful, you can send the urine for cytology as well, which is something I didn't mention in my talk. And you know, give them 3 months of treatment, and if it doesn't get better, consider a cystoscopy yourself or getting a urologist to do a cystoscopy. And if that is then normal and they still have bad symptoms, then consider Botox, because I think Botox is probably a little bit more accessible. But don't forget your intestines. It is a very nice treatment with the right motivations. It is well reimbursed by the medical aids, and so that's something that I do need to think about. But absolutely, try your empiric treatments first, and then yeah, Kanisa Makamba, thanks for your questions. 2 questions from you. Bladder wall thickness. Do you prefer the bladder distended or empty? I don't think it makes such a big difference, and often you don't really have a choice. But I think I think a very distended bladder is obviously not going to be useful, and I think most of the data is with about a bladder between 50 to 200 mils. So, and I think when it's thick on an empty bladder, it is much more useful. So I don't really know what they use to collect the data. But yeah, I think anything, I do find that it's not as useful when the patient is very distended. So maybe go and get them to empty the bladder. And then again from Kanisa, for the use of BDAVP for nocturia, is it important to exclude other causes of nocturia? I think very useful. Bladder diary is useful if you don't want to get a physician involved. And but then again, I think empiric treatment with enough counseling and with proper investigation, including blood pressure and renal function, I think it is something that I do find very useful in some patients. Yeah, so those are the questions. Another question. Thanks very much. Anonymous attendee, what is your take on the use of intravesical lignocaine, heparin, bicarb, and how often and how long you're supposed to use it? So yes, this is a cocktail that I started using at Curtis Ski about 15 years ago, and I'm not sure if they still use it, but it certainly gave an improvement in some patients. It is quite labor intensive because you have to do 8 treatments over the course of a week, of 8 weeks, weekly, installations. And it's, so again, labor intensive, quite cheap. I mean, lignocaine, heparin, bicarb are available in most hospitals. And so, yeah, 8 treatments, patients who do desperate. But I think if you are going to use some intravesical treatment, rather go for something like cystostatic if the patients can afford it. It's very expensive, 2,000 Rand per treatment, but it certainly is the one with the more evidence and much more worthwhile in terms of time for the patient. Yeah. So yeah, thanks. I think that's all the questions. I do appreciate all the people joining tonight. I look forward to having you all back next week. Hopefully my friend Peter has had a great birthday, and absolutely pleasure having you on, and we look forward to seeing you next week for Trudy Smith talking about menopause again. So and again, thanks to Ashley, and yeah, have a good evening everyone, and as Peter always says, safe home, and enjoy the use of your own mini bar. Yes,
we're gonna play out with the video.
Oh yes, and thanks very much, Ash, for reminding me about that. So we'll be playing out with the video from Stellis. Thanks so much.
Betmega uses the innovative and patented Oral Controlled Absorption System, or OCAS, to ensure optimal delivery of mirabegron in patients with an overactive bladder. Let's take a closer look at how Betmega OCAS works. Betmega OCAS is a hydrophilic gel-forming matrix tablet that ensures gastrointestinal tract. This complete hydration ensures continuous and consistent release of mirabegron throughout the entire length of the gastrointestinal tract. The more consistent release and absorption seen with OCAS versus an immediate release formulation is less affected by food. Betmega OCAS with a once daily dose ensures that your OAB patient can experience 24-hour symptom control and improved quality of life. Betmega OCAS is an innovative and patented technology that ensures continuous release of mirabegron throughout the entire gastrointestinal tract, irrespective of food intake. Betmega OCAS ensures 24-hour symptom control and improved quality of life for patients with overactive bladder.
Thanks very much, everybody. Have a good evening. Bye.